Lovely. Okay. So I thought what we'd do tonight, I'm going to start off giving an overview of the Hub initiative and project, and then I'll hand over to Dr. Nadya, who will give a clinical case of treatment in the healthy population. First, like to acknowledge the traditional owners of the lands that we coming to you from Gadigal land tonight. And like to acknowledge their continued relationship with those owners. So a little bit of background. Jean Hales did a survey around about 22-23, which showed that almost 65% of women have severe menopausal symptoms. And we know that's well documented that there's a significant increased risk of depression and anxiety around this phase in life. And that women who have already got a background of premenstrual syndrome or PMDD are at higher risk of suicide in their 40s. We also know that there is a small percentage of women who will have severe flushes forever, contrary to some women who think that it's a phase that they'll go through and it will pass. And the Australian Institute of Superannuation Trustees have estimated that menopause will cost the economy over $17 billion a year, and that was in their 2023 report. So with that in mind, the New South Wales government committed to pledge some funds to create a task force, menopause task force, with the Agency of Clinical Innovation at the helm of that. And the idea is to establish a statewide menopause service for people with severe and complex symptoms of menopause. So the snapshot here is just taken from the ACI web page. You can go onto the ACI, put in menopause. It will have their clinical briefs, their clinical priorities on there. And the idea is for there to be, or there are now, 4 medically led hubs that have a multidisciplinary team. And each hub has a cluster of referral sites that it is linked to in the different LHDs. Unfortunately, the referral sites were not given any allocated budget for medical. So at those referral sites is a menopause coordinator that is either a physio, dietitian, women's health nurse, and they usually have some administrative help, and that's about it. And obviously, one of the priorities was to keep GPs at the forefront of it as the first point of contact for women experiencing these symptoms with perimenopause and menopause. So this is how it's set up at the moment. There's the 4 main hubs. So there's one at North Shore. There's one with us at Randwick at the Royal for South East Sydney. Southwest Sydney hub is in Campbelltown, and the rural network hub is up in the Hunter, I think at Lambton there. And each of these have the LHD. So the South East Sydney hub, it services Sydney LHD, Justice Health and Forensic Mental Health Network, Illawarra, Shoalhaven, and Southern New South Wales. So quite a large area all the way down to the Victorian border. And so obviously, you know, with these referral sites, just having a menopause coordinator there, if any of the women that they see need medical treatment, then they will be referred up to the hub. And we have been using lots of telehealth for these women in those areas. So we've been lucky enough at the Royal Hospital for Women to have had a menopause clinic for a long time. It was originally established by Dr. Barry Wren back in 1978, and then taken over by Prof. Eden, who's still our director to this day. It originally operated out of the Gynae outpatients department at the Royal and was supported by the Royal Hospital for Women nursing staff and admin and allied health. There was no specific triage criteria. It was basically anybody could be referred, and almost 2 years ago, which I can't believe when I did this slide. I was like, oh my God, it's 2 years. We started to transition to the hub model. So previously, yes, as I said, no referral criteria, all comers were referred, including well women who could be managed in the community by their primary care provider. Now our clinics are split into sort of 4 streams. We have a medically complex clinic, so women who may have contraindications to MHT, like migraines, clotting history, that sort of thing. We do a menopause after cancer clinic or medically induced clinic. And that also includes women who are at high risk of cancer, so may have a genetic mutation or are being looked after by a hereditary cancer clinic. And we're lucky enough to have a psychiatrist as part of our hub, and we have a dedicated hormone and mood clinic for women who may have a history of PMDD or other mental health issues going through the menopause phase. And we have a premature ovarian insufficiency for women under the age of 40. The weller women that have been referred to us, we stopped accepting those referrals at the beginning of this year, and those clinics are slowly being phased out. I think we've seen our final new patient from those referrals, historic referrals, and really we're just doing follow-ups now and sort of discharging them or transferring them to one of the complex clinics if need be. For those weller women, we want to support them and not just basically say, no, you don't fit criteria and on you go. So we give them a call. We do offer a comprehensive women's health assessment, talking about screening, lifestyle factors, that sort of thing. We provide information and resources to them. So we give them Gene Health, Healthy Bones Australia, the Australia Menopause Society fact sheets, that sort of thing. We provide a list of GPs in area that have been signed up to the Australasian Menopause Society. So we provide that to them. One exception to the weller women cohort are the priority populations. So those who may have socioeconomic complexities. We are actually at the moment setting up a priority populations clinic. We've got one of the sexual health physicians from Sydney Sexual Health is coming to do some training with us with a view to doing clinics in that area. And that sort of, includes but not limited to homeless people, rough sleepers, women, sex workers, that sort of thing. We also want to support our GP colleagues through this. And in 2026, we're hoping to commence clinical placements. We've already been sort of doing it on an ad hoc basis. We do have GPs who come and contact us and want to come and sit in clinics. So it's a little bit ad hoc, as I said, but hopefully in 2026, we'll be able to set up a program similar to the antenatal shared care program, where we're hoping that the PHN will advertise some dates for us. GPs can contact us and sign in to come and sit in on those clinics. We also provide, when we have a lady who doesn't fit criteria, we also send a letter to the GP explaining why they haven't made the criteria for the hub, and we have a list of these resources for the GPs. So you've got the Monash toolkit, the practitioner's toolkit, which is a very comprehensive algorithm for looking after weller women with menopause. We give them information for Meno Echo. That's a bi-monthly free webinar for GPs they can sign up to, and give them information on other courses as well. So We're also hoping in 2026 to have a advice line. We're waiting on a fellow coming in 2026 who will hopefully be able to monitor and look after that for our GPs. Next slide. So, gone too far. So the hub referral criteria can be found on the Health Pathways website. It is a little bit confusing. We do often get phone calls from GPs who are unable to find us because I think there's a couple of menopause options on there, but it's the menopause specialised assessment. We accept e-referrals from GPs and they can be found on HealthLink. I'm sure you guys know more about that than I do. And I think the link to the Health Pathways is embedded in HealthLink, if I'm correct. And this is just some of our criteria that I've mentioned before. So the medically complex. We also see women who the GP has been trying to look after, but the symptoms are not being well managed on their usual MHT doses. So that's another one of our criteria as well. Yes, thanks, Martina. I thought it was. So I will now pass over to Nadya.
Hello. I thought I'd do a short case presentation of a typical well woman presenting with menopause symptoms, and then just a little bit of information on the evidence of HRT and breast cancer, a little overview, being that the fear of breast cancer is one of the main reasons that HRT and menopause medicine dropped off the radar about a bit over 20 years ago, and why it's taken a bit of time for it to come back. So this short case is Miss Kate. She's a 51-year-old woman presenting with 2 years of worsening symptoms. She has vasomotor symptoms with hot flushes 10 times a day and at least 3 episodes at night of waking up with night sweats. She is also experiencing mood symptoms with new onset of anxiety without previous history, irritability, and at times low mood and low motivation. Her libido is currently okay, but she does experience some localized symptoms with vaginal dryness and discomfort with sexual activity. And in general, she also mentions that her skin's looking drier and more uncomfortable, itchy, and she's starting to put on weight. And one of her main questions is it safe for me to have HRT, doc? My friends all love it and think I should be on it, but there's breast cancer in my family. So, of course, we want a little bit more information about her. Her gynae history is that she is properly postmenopausal, and her last menstrual period was over 12 months ago, being 18 months. And before that, they were infrequent, having spaced out for at least a year. Her medical history is quite uncomplicated, with some GORD and an arthroscopy for a meniscal tear. She does have a PPI on occasion, but otherwise no allergies. She doesn't smoke, but her alcohol intake, when you screen her for that, is 9 standard drinks per week, which is a little over healthy guidelines. Her family history does include breast cancer, with both her mother and her maternal cousin having breast cancer. There are more women in the family unaffected, and there was a BRCA test done for her maternal cousin, which was negative. There is also a family history of osteoporosis, with both her mother and her maternal aunt being affected and on medications for this. A quick look at her lifestyle shows that she does eat a full diet. She exercises, with running 3 times a week. So generally a healthy woman, but maybe a bit more alcohol than we would normally recommend. So with a usual midlife woman's health assessment, you're going to ask about screening with, are you up to date with mammograms, fecal occult blood tests? And they are. Her pap smear is due, and she had seen you a few months ago and had some general screening blood tests which were normal, and it happened to include a vitamin D at the time. On examination, because she does need a pap smear, you do take the pap smear and everything looked pretty normal, and there was nothing else to account for the discomfort with sexual activity. And she was normotensive and her weight is in the normal range. So investigations, you send off the pap smear as it's due, but there's no real need for a hormonal profile at this stage because she's a well woman having typical symptoms at a typical age, and so it doesn't really matter what her FSH or her estrogen level is. We're going to treat her the same. So options for management. Of course, we can use menopause hormone therapy systemically for her vasomotor symptoms and her mood. We can use hormone therapy topically for the genitourinary symptoms of menopause, which can include the dryness, painful sexual activity, and bladder overactivity or recurrent UTIs. We could also consider non-hormonal treatments for her vasomotor and mood symptoms. And really, what would be the advantages of hormone therapy in this? And it has the potential to, from this perspective, to help all of her symptoms, so the vasomotor, the mood, with potentially less side effects than some of the other options. And also it's bone protective, reducing the risk of fractures in the long term. And as she's within 10 years of her menopause, there is some cardiovascular protection as well. And there's also some diabetes risk reduction. So maybe a few reasons why MHT might be a good idea. So how do I approach the risk for breast cancer discussion with a patient? I thought I'd look at the evidence as well as how I approach it, the evidence that I base that on, and then my treatment for this patient. So with the breast cancer risk, I always really start with what is the background risk for this patient, which is something GPs would be doing regularly with a woman in midlife once they start their mammograms. Of course, there's the iPrevent calculator that is endorsed by the RACGP. It's not for BRCA carriers or breast cancer survivors, but it considers all the risks and gives guidance for screening. It includes modifiable and non-modifiable factors, and it takes in quite a detailed family history, as well as lifestyle factors. And it does take a while to do, and sometimes patients can do it on their own, but I did it myself, and it took me 10 minutes to put all my family members in. So without that amount of time, you can also look at this infographic that I like to use. It's from the British Menopause Society, and it's a really clear pictorial view of how different risks or risk factors influence the risk, with the extra cases attributable to that factor being in purple, and the less or decreased risk factors attributed to in green. So, for example, there are additional 24 cases for women who are overweight or obese, and a less, can't see the number there, but I think it's 7 cases for women who are exercising regularly. So it's a nice way for women to sort of reflect on their own situation. Of course, non-modifiable risk factors are a fact of life, and we need to just be aware of how they influence our screening. But what can we do about it with our lifestyle? Exercise, alcohol, smoking, weight reduction. So that's where I start, because a lot of women need to sort of look at this to begin with. And then what is the evidence, and why are we so excited about HRT and breast cancer? So the WHI was the pivotal trial and the largest randomized controlled trial of HRT looking at breast cancer as one of its outcomes. It was randomized, it was an RCT. It used synthetic medroxyprogesterone acetate as the progestin, and equine estrogen or conjugated equine estrogen. They did see a relative risk of 1.26 for women taking this form of HRT. This was an absolute risk calculated as an extra 8 cases per 10,000 women per year taking HRT. And then they also found in one arm of the trial where only the estrogen was used that there was a decrease in the risk with a relative risk of 0.78 and a similar drop in the absolute risk. And also with the long-term follow-up from the WHI, there was no increased mortality from breast cancer, despite these numbers, and also no increased risk with less than 5 years of use. But it was publicised widely and quite dramatically at the time and led to almost overnight significant drop-off in the use of MHT and the prescriptions of MHT. So then there was a prospective cohort study done in France. It looked at 80,000 postmenopausal women, followed them for about 8 years, and looked to see their breast cancer risk depending on what type of progestin they used in their combined MHT. And they found that the synthetic progestins elevated the risk, but using the body identical progesterone did not. There was a relative risk of 1.08, which was non-significant. And the dydrogesterone, which is a similar but slightly synthetic progestin, had a much smaller increase in risk of 1.16 with the relative risk. They also noted that transdermal or oral estrogen made no difference to the breast cancer risk. So looking at these studies, it seems that the breast cancer risk may be due to the type of progestin. Unfortunately, most of the epidemiological evidence showing a significant increase in breast cancer, like the Lancet review that came out in 2019, is heavily weighted on the large numbers in studies that are using synthetic progestins. So we really do need more focus on combined HRT using progesterone or dydrogesterone only to be able to give very good long-term data and advice to women. Then there's a lot of more interesting evidence that complicates this. There is evidence that, a group head by a scientist called Yu showed that the use of HRT pre a breast cancer diagnosis actually decreased the risk of death from breast cancer or any cause, which was a very interesting finding. They also find in autopsy studies that there is a 1.3% chance of finding an undetected very small breast cancer and about 9% risk of DCIS in autopsies, which has been undiagnosed and undetected. And the evidence of hormones on breast cancer is really complex. There are lab studies showing that there is apoptosis with certain types of estrogen, and indeed estrogen has been used in the past as a metastatic breast cancer treatment, maybe from downregulating receptors. That's the theory. And many are questioning whether the effect of MHT in the studies is because it's stimulating an existing breast cancer. And so the diagnosis becomes earlier than it would have been detected naturally. And with these studies, with their fixed follow-up time intervals, are they bringing forward some future diagnoses into their time frame, into their study window, and therefore increasing the numbers? And there's some really great cell biology studies that are done with breast cancer. And when they're looking at the initiation of breast cancer, it appears to come from these long-living breast stem cells that are influenced by genetic and epigenetic factors that can date back to in the womb and earlier in life. So it's not all as simple as MHT. And early breast cancers are actually influenced by locally made estrogen from the breast tissue, because normal breast has 20 times the level of estradiol than serum does. And this is in part due to very high levels of aromatase and sulfatase enzymes that convert the fat-derived estrone, or E1, into E2. So it's way more complicated than the level of estradiol in the blood. And the other thought is that the progestin is thought to be a promoter. So it does promote the growth of existing breast cancer cells in vitro, excuse me, getting myself mixed up. But if you're interested in the real complexity of breast cancer and hormones, our clinical leader and guru, Prof. Eden, wrote an amazing paper summarising this last year. And I've got a reference to this at the end of the talk if you'd like to read more. It's very complicated and interesting. But there's also some evidence that even the Lancet trial that I mentioned before, their meta-analysis in 2019, which included 58 epidemiological studies and did show an increased risk of breast cancer, which of course was mainly relying on women using synthetic progestins, they still did not show an increased risk of breast cancer for women who had a family history. So there was no additive effect if the women had a family history of breast cancer. And this was not including women with a history who were BRCA carriers. So having this very long chat with a patient, or abbreviated probably in real life, weighing up the current quality of life issues she's facing with her risk of breast cancer, she decided to use MHT, a trial of MHT, to see if the effect was beneficial for her quality of life. She asked to use body identical estradiol and progesterone, understanding the different risks with different types of progestins, and decided to continue with her mammographic surveillance. She is now going to try and decrease her alcohol in line with those risks, and also was quite excited to know that it may decrease her risk of osteoporosis later. So starting a transdermal estrogen patch at mid-level doses, and or equally 2 pumps of gel is the other option, and 100 milligrams of prometrium at night because of the sedating effect. And if you'd like to look at some of the references where I've got this information from, that's on your screen.